All right, we're going to take a little trip to Switzerland now. So, hey, Dave MadMax6. Hey, Dr. Ren. I have a quite simple question, but I would like your input from the input from an expert. Since I have not yet started any testosterone therapy, would like to one day. What is the difference between testosterone cypionate and testosterone enanthate? And if so, how do application dosage or side effect differ one from the next? The first one is more commonly used in the U.S., the latter more in Europe. He's obviously from Switzerland, so he wants to know.
Good question. It is a simple one.
Okay.
One carbon.
And what is
There's one carbon difference between testosterone cypionate molecule and testosterone enanthate molecule. And what that really amounts to, he pointed out the difference in the countries. In this country, testosterone cypionate is cheaper, considerably cheaper than enanthate. In any country, that one carbon difference really amounts to a 1 day half-life difference. In other words, the half-life for testosterone cypionate is generally accepted to be 8 days, whereas for enanthate, it's 7 days.
Oh, wow.
So I argue that it's testosterone cypionate is across the board in the U.S. because we don't have access to others like testosterone undecanoate, although that's not true. I'm sorry, that has changed recently. But doctors can't freely prescribe it. I believe they make you jump through some hoops to do it in this country, which is fine. But anyway, for the most part, testosterone cypionate is cheaper, less painful upon injection, and has the longest half-life easily available in the U.S.
Okay.
In Switzerland, I don't know, he might want to look into undecanoate because it's a different ester. It'll last longer. It takes the body longer to break it down.
So it's more sustained release, you'd say?
Yeah.
Kind of.
So fewer injections is the bottom line. It's the best way to put it.
Gotcha.
But yeah, that's a simple answer. I hope a simple answer to a simple question.
Yeah, but it has nothing to do with the quality of it.
No, all it is a testosterone molecule that's been bound up. It's in this esterified form. Without getting into the old high school chemistry, it's bonded in such a way that the body has to spend some energy to break off that molecule of testosterone, and it effectuates time release action.
Gotcha. Very cool. Thank you, Doc. Okay, hey Dave, this is moderator Magnus82 from the forum ANASCI. We have a thread going on with all Dr. Ryan's video. They are fantastic. I'm giving you some props today because people are really happy with you. A member posted a link to ask a question. He has already answered one, which was great. I have one I'd like to see if he could clear up. When using injectable metallate orals, I don't know what that means. Is the liver toxicity reduced by missing the first pass, or does it have to be cleaved or processed by the liver anyway? Do you understand why?
Methylated?
Yeah.
So you're taking an oral, like methyl test and injecting it?
I guess. When using injectable methylated orals. What does he do? Is he breaking it down?
Orals that they're injecting.
Yeah.
I don't imagine. I'll try and answer the question.
Is the liver toxicity reduced by missing? Okay, so he basically is taking some tabs and basically crushing them, and inject them. Is what I'm getting.
Well, let me just answer via the concept. Okay, the whole idea of methylating anything, we'll stick with testosterone, is to slow the ability of the liver to break it down into another metabolite. And that sounded great to us in the beginning because we thought, wow, we can have a longer acting substance. The problem is the liver's not giving up, let's put it that way. So it's going to keep trying to break it down. It makes the liver work too hard, and it taxes the liver. The idea of taking an oral version and injecting it is a very simple one in the sense that what we call the first pass of the liver occurs whenever you ingest something. The liver's part of what we lump into the GI tract, and so it goes from the mouth eventually through the liver before it gets to the body. So depending upon the substance and how much of it gets metabolized into something else or not, some things pass through the body unchanged. That first pass can make a big difference. If you inject it, it gets into the bloodstream right? Conceivably before having to pass through the liver. So you avoid that first pass effect, and so you get it to where it needs to, where you want it to go without being jiggered by the liver at all. So that would be the only advantage to taking that oral form and making it injectable. After that, though, it's still going to be a pain on the liver, meaning it's going to have to pass through the portal system at some point and hit the liver. If it goes through the blood, it hits the liver, and it's going to be hard for the liver to break down. So,
would you say it's better though, the way he's doing it? I mean, he's probably
just based upon the theory. Yes, you're avoiding
at least once.
that
you get a free pass.
That first pass. It's better in the sense that if your goal is to get it to the target tissue without the liver adjusting it, then yes, you've done a better job. But as far as harming the liver, conceivably it would be a little bit better, but I have to think about that one to see, because eventually it is hitting the liver. It's in the system. It has to be metabolized and excreted. Probably not the best idea, just without researching. I don't know if everyone's done this and there's evidence. I mean, I can only answer conceptually because, I'm not the head of a study group that looks into these things, but I can answer the questions logically based upon physiology, but that's as much as I can do, so don't, as in all my comments and information, this is not medical advice, but just my information based upon what I know is fact.
Yeah. Do you remember back in the days, and I haven't heard anybody lately talk about that, but people would sometimes take oral and use DMSO with it to actually rub it on the skin. Was that a good idea, or was that better than?
Well, again, conceptually, it's the idea that you're using a solvent, DMSO, which has been around for a long time as a fantastic, in general, solvent. It used to be a horse liniment. It works wonders. I don't know if you ever had like a sore Achilles tendon. Boy, slap some of that on with some diclofenac, an NSAID, for example, and the DMSO helps drive that through the skin. And by the way, it drives anything along with it through the skin, so you want to make sure your skin is nice and clean. Yeah. A little Dove soap's not going to hurt you, but if you've just been picking tomatoes in the garden, whatever's on your ankles is not going to be good for you necessarily. But yeah, DMSO, it can be used to help anything with transdermal absorption. I use it sometimes. Some people don't absorb the hormone creams very easily. Not often, but sometimes to get better absorption, we'll mix a little bit of 10% DMSO into the cream to help it get through the skin.
So it's still around.
Oh yeah. No,
it used to be talked about a lot more in the past than it is now. I don't know why.
It was legal, then it was illegal, over the counter, and now it's legal again.
I see. And that's what I was telling you before. How do you, whenever something is legal, then goes illegal and gets legal, how do you know all that? How are you being notified? You have to research it every time?
Yeah, personally? I mean, now, fortunately, there's programs like, one of my favorites is Hippocrates, which is on my iPhone. And you can look up drugs as well as disease conditions, and you can look at the schedule status, the average cost, so you can help patients out. They even have pictures, which sounds like a plug for Hippocrates, but it's a good program. Yeah. But if there's any question, you can go to a program like that or just look it up online.
That's great.
But yeah, you gotta. Things are changing all the time, and we talked about it a little bit earlier. You never know the reason. I mean, there's the obvious ones where it's killing people. We need to get it off the market, or the risk versus benefit is questionable based on the latest study, so the FDA changes their mind or whatnot.
Or politics.
Unfortunately politics, which I think is what DMSO was all about. It was a horse liniment. Never had a problem with it. I don't know the specifics behind it, but we were like, okay, is it illegal? Well, I hear that, and this may be changed now, creatine is considered illegal or prescription only in France.
Really?
That's what I heard.
Wow.
So it depends on the government, so that's where the politics comes in, but their interpretation of the studies.
But Anavar or Oxandrolone also had that. I remember that back in the days, I don't know that it was widely available, and then for a while they stopped manufacturing it in the States. And then they started remaking it under Oxandrolone, and so it's been re-available for a few years. But it was a few years where it was not, you couldn't find it here, not legally at least.
We almost lost Nandrolone and possibly Oxandrolone from this market because, yeah, I mean, again, people's interpretation of what's a good use versus not a good use.
Yeah.
I mean, you know, the medical establishment says, hey, it's not a good use for bodybuilders. It's not acceptable. So if it's being used for that purpose and the people in charge don't agree, then yeah, it's more likely to be yanked off the market. There was an issue in 2011 with clinics in Florida, you know, the pill mills and all that, and rubber stamping prescriptions and selling things by prescription over the internet. They brought nandrolone, specifically and oxandrolone, under fire.
Wow.
And the companies, you know, it's not a big portion of their income, were ready to say, you know what, we just won't make it anymore. How's that? So we don't cause any problems. And so, yeah, I mean, that's just an example, one example of how these things can be taken off the market or change the schedule. Schedule meaning, you know, are they, at what level are they controlled?
Right.
You know, even if you can get, even if you have to use a prescription, you know, there's certain levels of control within even RXs.
Gotcha. All right, thank you, Doc. Okay, so this one, Doc. Hi, long time no videos. I'm waiting for my question to be answered. What about using Masteron instead of Arimidex? Thank you.
Two completely different substances. Masteron is a anabolic steroid, and Arimidex is an aromatase inhibitor. We know what an anabolic steroid is. An aromatase inhibitor is something that blocks the conversion that occurs typically in the liver from testosterone into estrogen. So to use Masteron in lieu of Arimidex would be a disaster. They're two totally different things. So I'm not sure if that's just a misunderstanding about a drug or a misprint or something, but those are, I mean, I don't know how to answer it any more simply than that.
They're just unrelated, yeah. Okay, very good, very good. Okay, Doc, so this is from a female. I'm 34 years old. I've been using steroids for 2 cycles, Test and Deca injectable. 10 weeks each cycle, followed by 30 days of PCT, and now I'm thinking of using Tren. Can you go into detail about Tren, pros and cons, and there are supplements I can take to help with side effect from Tren? I do have to take Test with Tren, or can I take it the Tren all by itself? So does she have to take
a lot to that question. First of all, at 34, again, I know I'm straddling 2 areas in all this, but as a physician, I have to say, you know, that if she's using it for hormone replacement therapy, not the best idea. And I know people are saying, well, we get that, but now talk to us as a community of bodybuilders. But I have to get that in there. Those are not your best choices for hormone replacement therapy or bodybuilding as a female. Okay, Trenbolone is very androgenic. It's got a lot of affinity for the receptor, and that would not be my first choice if you're trying to avoid, you know, the secondary sex characteristic effects of, you know, the androgenic effects of a steroid or any hormone. So, you know, women in general tend to do better with the highly anabolic versus highly androgenic hormones like Anavar. You know, there's a lot of argument about what you know, because it's all terminology. Oh, Winstrol is really, really clean. Well, and Winstrol is a DHT derivative, so that might not go over so well, even though it's clean, very anabolic in a female, just because DHT is what causes all the negative side effects, like hair in the wrong places or hair loss in the right places, and acne and that sort of thing. So best bet is to use testosterone as your hormone replacement therapy. But again, as a bodybuilder using these substances outside of, you know, medical mainstream, you got to be careful for the side effects when the things you're choosing have a lot of androgenic effects as well. So, and you know, those, not just hair, and some of these things are permanent, by the way.
Mm-hmm.
You know, we don't talk about it that much, but I'm sure in the bodybuilding community, you know, clitoral enlargement, that can be permanent. Some of the facial changes can be permanent. You know, you have a little window there when you go, uh-oh, something's not looking right, where, you know, you can stop and things will reverse. But at some point, it ain't changing. The deepening of the voice, the thickening of the vocal cords, at some point that becomes permanent. So you want to be careful. You know, after all, at the end of the day, the purpose of bodybuilding, right, if I understand it properly, is to look better, okay? Hopefully it's to feel better and be better, more healthy. You know, well, I guess sounding better. You know, you don't want to sound like this because your vocal cords have gotten so thick, and you don't want to be missing hair on the top of your head because you took steroids improperly. So for females in general, stick with the ones that are highly anabolic versus androgenic.
And what would you say the best choice for women would be aside from Anavar?
You know, I, albeit rarely, but I do prescribe sometimes oxandrolone, Anavar, for females who have had estrogen-sensitive cancers but have no testosterone, for the reason that it's very anabolic without being androgenic, so it's very safe. You're not going to, you know, first of all, it's got to be in your genes or not, you know, the hair in the wrong places or whatever. But if she has the genes for, you know, the one that grandma had on her chin, this shouldn't activate it as easily because it won't convert to dihydrotestosterone, but it also doesn't convert to estrogen. So that's one I use with, you know, again, rarely, but for certain females. So that one I can speak to directly. I mean, that one's a safe one. Other than that, you know, testosterone, that's what you created, you know, and supposed to have on board is relatively safe also.
Good.
Does that answer the question?
Yep.
Okay.